Okay, great. So thank you for taking the time, Gareth. So
no problem, Klaus.
Can you tell us why was it important to update the diagnostic criteria for NF1? Who was involved in the process and what methods were used?
So we felt it was time to update the criteria because they date back, in fact, to 1987 from the National Institutes of Health meeting, where NF1 and NF2 were separated out as different conditions. And obviously quite a lot has happened since that time, not least that the genes have been identified for NF1 in 1990, and that there are now conditions that are overlapping with NF1, in particular Legius Syndrome, which is caused by genetic faults in a gene called SPRED1, which causes a lot of overlap, particularly in the pigmentary features, so the cafe au lait patches, the freckles in the non-sun exposed parts of the body. And because of those two issues, we felt it was time to update the guideline to include genetic testing element to it, but also to clarify some of the points to make them clearer. So the original criteria were very good, but they could be improved on, and that was the reason we did this. In terms of who set out to do this, there was a main group of 6 clinicians and scientists supported by Patrice from the Children's Tumor Foundation in the States, which included both NF1 and NF2 specialists. Susan Houston from Manchester, UK, has been known for a very long time as an NF1 specialist. Pierre Volkenstein, again, a very strong NF1 specialist from Paris, a dermatologist. Scott Plotkin and myself, who work on both NF1 and NF2 clinically, and Ludwin Messiaen, who works on the molecular, the genetic testing side of things. So we felt this was a strong sort of leadership group, and adding to that, we had also a very strong group of NF1 clinicians and scientists who were involved in a meeting in New York to try and pull together the different areas. And then, as well as that, we went through a process called a Delphi process, where we created recommendations for diagnostic criteria and then put them to an NF1 specialist group and also a group of clinicians who weren't particularly specialist in NF1 to try it out on them to basically approve the recommendations. And if we had strong overall consensus that a recommendation was good, then that sort of approved the process. And so we went through a number of rounds of this Delphi process to get to the final agreed diagnostic criteria for NF1.
Great, thank you. And what is now new in the updated diagnostic criteria?
So the main new thing is that there is something called a heterozygous pathogenic NF1 variant with allele frequency of 50% in apparently normal tissue such as blood cells. So what that means is we have identified in a blood sample a genetic fault in the NF1 gene that is a causative fault that is causing NF1. And that now stands as one of the 2 criteria. So in order to diagnose NF1, you still need 6 cafe au lait patches or one of the other criteria, neurofibromas or an optic pathway glioma, as well as the genetic fault to make the diagnosis. But what this means is we can bring forward the diagnosis, particularly in young children who may just have 6 cafe au lait patches, by doing a blood test, rather than wait for the additional features to appear later on. And I think that's very important because often parents are left worried about, is my child going to become NF1 or not? And a negative test would be very helpful in reassuring parents that maybe their child with a few Café patches is not going to go on to develop into NF1. So the second major area where genetic testing is important, and there is a new subdivision of the criteria, is in what we call mosaic NF1. Now, this is where the genetic fault in the NF1 gene is not in all the cells. In other words, was not inherited in the egg or sperm that made that person, but actually occurred later on during development. And this could present, for instance, as Café patches or pigment in just one segment of the body, or it might actually mean that someone looks fairly typical for NF1, but actually has a low level of the genetic fault identifiable in blood and a number of other tissues. And where this is particularly important is that we can now do testing on Café patches, and if we find an identical genetic fault in NF1 in two separate Café patches, we can diagnose NF1. Now, this is as a mosaic. This is important not only because the chances of passing on the gene fault is much less if you don't carry the gene fault in all your cells, but mosaic or segmental NF1 is usually much milder and means that individuals are not at such risk of the tumor development that would happen in someone who had the full-blown form of NF1. So the other areas are more clarifications. So for the tumors on the optic nerve that can cause visual loss, we now have made those optic pathway gliomas to make it absolutely clear. And there are also some changes on the iris, the colored part of the eye, called Lisch nodules. And that in addition to these, we've enabled ophthalmologists to be able to diagnose as a diagnostic feature other things that are similar to this in terms of choroidal abnormalities. So these are abnormalities, again, in that part of the eye, as well as specific testing with technology called coherence tomography. So these are really not things that you'll even be aware of. They're not harmful, but it means an ophthalmologist can make a diagnosis, an eye specialist can make a diagnosis. And the other area is in the bony problems, so where the bones don't form properly, called dysplasia. We've specifically said that anterolateral bowing of the tibia, which is the bone between the knee and the ankle, the big bone between the knee and the ankle, is a more specific way of putting that issue. And the final area of clarification is that where someone has just pigmentary features, particularly if this is in families where there are no other features other than the Café patches and freckling, that really we strongly advise testing the SPRED1 gene to differentiate NF1 from Legius Syndrome. So those are the main areas. The final thing is that where in the past we accepted a first-degree relative having NF1, we now make it clear that this is a child of a parent who meets diagnostic criteria rather than, for instance, a sibling. So what we don't want to happen is for two young children who just have the pigmentary features with no affected parent being diagnosed as NF1, because the danger here is there is another overlapping spectrum of conditions caused by genetic faults in mismatch repair genes, where they're in both copies, that can mimic NF1 in the early period. And so again, for first degree relative, we mean a parent rather than a sibling with features suggestive of NF1. So a lot of this is just tweaking. The criteria have really served their purpose extremely well over the years, but we thought it was very important to get in the genetic testing. And in the last maybe 5-10 years, the importance of genetic testing has become more clear, and that's particularly so in mosaic NF1, but also there are some genetic faults which are associated with mild NF1, some faults that are associated with more severe NF1. And so undertaking genetic testing is something we are now encouraging.
Great. Maybe you can talk a little bit about the new diagnostic criteria, or the first actually, for Legius syndrome, because obviously when the original diagnostic criteria developed, Legius syndrome wasn't even known. So maybe you can explain a little bit what the diagnostic criteria for Legius syndrome looks like and why it was important to develop those as well.
Okay, so the main area where there's is a concern that it's more likely to be Legius syndrome is where particularly there's a family history of 6 or more Kappa-A patches, and no other NF1 related diagnostic criteria except freckling in the axilla and groin area. And you actually require identifying a fault in the SPRED1 gene in blood at what we call a 50% allele frequency, which means it's in all of the cells on one copy. This is where we specifically are saying, so you meet the criteria if you have 6 or more Kappa-A macules, but no other NF1 related diagnostic criteria apart from freckling, and a genetic fault in SPRED1. And so that is the main issue, and that is why if you only have pigmentary features in a child or in a family, that it's really important to differentiate by doing genetic testing on a blood sample between NF1 and SPRED1.
And I understand that this is also important to spare a child or an adult with Legius syndrome from unnecessary testing and assessments, correct?
Absolutely, because there's really no evidence that Legius syndrome predisposes to tumors, so no evidence for neurofibromas, no evidence for malignant tumors, gliomas, no evidence for breast cancer. So we wouldn't want to be subjecting a child and an adult later on to unnecessary clinical and radiological examination when actually they don't require it.
Is there a plan to also develop diagnostic criteria for CMMRD or other genetic conditions that mimic NF1, like Legius syndrome?
So there are diagnostic criteria for CMMRD. So this is congenital mismatch repair deficiency. So this is where children have 2 faulty copies of one of the mismatch repair genes. PMS2 is perhaps the most common of those. So there is a separate, outside of NF1 diagnostic criteria development group. And in that condition, you require identifying a fault in both copies of one of the mismatch repair genes that is a clinically relevant genetic fault. And in those individuals, the reason is that there is a very, very high risk of childhood and early adulthood malignancy, malignant brain tumors, etc., which is far, far worse than NF1. And that is why in a child, particularly who has untypical Kappa-A patches, who may be small, have a smaller head, that you need to be considering the possibility, if they don't have an NF1 genetic fault, that they could have this congenital mismatch repair deficiency.
So thank you. The guidelines, the new diagnostic criteria has just recently been published in Nature. Where do we go from here?
Well, it's in a Nature journal. It's actually Genetics in Medicine. Yes, that's correct. Yeah.
Sorry. And where do we go from here? Do you expect there's going to be some additional changes made now after the publication? Is this sort of a test phase now, or?
Yeah. So the plan is that this will be reviewed on a regular basis, maybe every 2 or 3 years. There will be the 6 people who were involved in really setting the ball rolling, who will continue to act as the sort of guardians, and that committee will obviously evolve over time. But essentially, we want there to be an iterative process where the guidelines are looked at again if there are any new criteria or any new overlapping genes or conditions, to make sure that what we call the sensitivity and specificity, so how accurate the criteria are at diagnosis, continue to be good.
And finally, you mentioned which clinicians, researchers have been involved. I know that also you have had several virtual meetings with patient representatives who were involved in this phase. Can you maybe talk a little bit about why this was important and how this contributed to the revised diagnostic criteria?
So yes, I mean, it is very important that patients and lay groups are on board with the criteria. We had a particular issue because this was not just NF1 and Legius Syndrome. We're currently going through with NF2 and schwannomatosis. We had a particular issue with whether we were going to do any renaming of the conditions, and there is going to be some renaming of NF2 and schwannomatosis that will occur as part of that part of the guideline. And it was really important to make sure we had patients and patient communities on board with any changes and hopefully supporting those changes, but also that there were a number of meetings where we set out the criteria for patient groups, both in Europe and in North America, where we were trying to explain what the new criteria were, what the changes were, and if there were any concerns from patient groups. And obviously, Klaas, you were very involved with that.
Is there a timeline for the update of the NF2 and the schwannomatosis diagnostic criteria that you can give a little preview?
So the article is pretty much finished. So it really is just final approval now from the committee, and then it's gone out to all of the authorship, which includes all of the clinicians and scientists involved in the main committee, who were in New York and part of the Delphi process. So some of those who were just NF1 specialists and did not particularly contribute to the NF2 and schwannomatosis are not authors on that. Similarly, some of the NF2 specialists and schwannomatosis specialists were not authors on the NF1 guideline if they were not major contributors to that process. Mm-hmm. So hopefully we should be seeing a publication, I would hope, before the end of the year.
Fantastic. So maybe to try a short summary, the main changes have been to emphasize on the importance of genetic testing in diagnosing NF1.
Correct.
To add some new clinical diagnostics that you mentioned before, and to also make sure that people who are not affected by NF1, but rather have Legius syndrome or another condition that mimics NF1 are differentiated and go a different care pathway than NF1 patients.
Absolutely. And I've just realized I didn't mention one of the most important people, who's Eric Legius, who was one of the 6 of us. So just to put that straight.
Yes, obviously. Thank you very much for taking the time and for guiding us through the process of developing these updated guidelines from the patient community. Of course, we're very happy to have this revised criteria at hand. It's also very important document for parents who witness the first features of NF1 in their child, and it definitely also helps them to get an early diagnosis as well.
Absolutely. We hope that this will mean that that a lot of NF1 children are diagnosed much earlier, particularly because they can use the genetic testing as a second criteria on top of cafe-au-lait patches.
Fantastic. So thank you once again for taking the time and doing this interview.
No problem. It's a pleasure. It's always a pleasure to talk to you, Klaus.
Thank you. You as well. Have a nice day. Bye.